I'm Rod Lawson. I'm one of the consultant respiratory physicians based at the Northern General. I also do quite a lot of community clinics and work closely with the community team, so I have a slightly unusual perspective on respiratory disease. And I'm going to be talking today about cough. In chronic cough, there are some things that allow you to stratify for risk, and particularly the red flag symptoms, you need to be aware of those. These would be things like hemoptysis that's persistent in the over 40s, and particularly those who've been smokers, and those with systemic features such as fevers, sweats and weight loss. Those are the patients who are going to need immediate referral, either on a 2-week wait for lung cancer, or if you think that it's things like TB, by urgent referral to those services. There are also other patients that you may feel there is some degree of risk. These are people who are more elderly smokers, where there aren't clear red flag symptoms, but by the fact that they've engaged in risk activities such as being smokers, you're a little more uncertain, and they're going to want sooner referral than the young, otherwise fit person who simply has a persistent, troublesome cough. Chronic cough is quite difficult to define in terms of its duration, and it goes back to what I said about risk stratification. If you've got somebody with red flag symptoms, you're going to treat that seriously pretty much straight away. If you've got somebody who's very young, fit, not a smoker, you're really going to be quite happy to see how things go for 8 weeks before taking any drastic actions. For an intermediate patient group who smoke and you feel a little less confident about, maybe 6 weeks would be a more realistic definition for the onset of what becomes a chronic cough. If you've got somebody with a chronic cough, and leaving aside those with the red flag symptoms who you're going to refer straight away, you can split cough into two main groups. There's patients with a wet cough and patients with a dry cough, and they're going to have rather different causes. And I would add to that those patients who you think there may be an occupational cause to their chronic cough, so that their cough is different on days at work, or they suspect some particular exposure in the workplace may be affecting them. Again, occupational related cough gets a bit complicated, and you're probably going to want to refer those patients early to a specialist service, which brings us back to the wet and the dry cough. Dry cough classically has 3 common causes, which are reflux, postnasal drip and asthma and its variants, whereas a chronic productive cough is going to be simple chronic bronchitis associated with cigarette smoking, or bronchiectasis, and there's not a whole lot of other causes above and beyond that are at all common. So you're going to be able to split patients into those groupings and plan your initial investigations and management according to that. Additional to those respiratory causes of cough that I've described there, it's always important to be aware of iatrogenic causes, and particularly here are the ACE inhibitors, which cause chronic cough in up to 10% of people who take them, and this will be a dry cough. And the important thing here is that once you discontinue the ACE inhibitor, the cough may continue for another month or 2 afterwards. It seems to take a while for the cough reflex to reset, so you shouldn't briefly discontinue it and presume it's not the ACE inhibitor. And that brings up a further point, which is to say that there are often more than one cause of chronic cough that's present, and these may be synergistic, so it's important to look at all the causes. So I'd always stop the ACE inhibitor if there's a chronic cough, even if you thought there was another cause there. There are good alternatives to using angiotensin II blockers, which will work just as well, and it avoids that additional synergy between different causes. Whatever the cause of the cough, you're going to want to do an up-to-date chest x-ray and see if there's an obvious cause on that, which, as well as looking at the common causes of chronic cough that are relatively benign, acts as a fail-safe against some of the more serious causes of cough, such as a lung neoplasm. So a chest x-ray is going to be essential. If you've got a productive cough, then you're going to want to culture the sputum, and normally that should be done both for routine organisms and for AFB as well, and it's good to do that on several occasions where you're trying to distinguish between a genuine pathological involvement and just transient contamination or colonisation. So you want to see what the general bacterial load is like. And if you do find pathogens, then obviously a simple trial of treatment of those to see if it settles the disease makes sense. So that's for a wet cough is chest x-ray, sputum culture and treating pathogens that are seen. In terms of a dry cough, specific tests are a little bit less useful. It's more about trial of therapy. Pretty much all patients should have a trial of anti-reflux therapy, and that needs to be vigorous and prolonged, and the suggestion there is that you should give a double dose of proton pump inhibitor, that you should combine that with ranitidine at night, then you should give regular Gaviscon too, and that needs to be trialled for 2 to 3 months before concluding that it's not working. It does take time to work. It's worth in pretty much all patients also trialling inhaled steroids, which need to be given in a reasonable dose, something like at least 400 micrograms twice a day of beclomethasone or higher, and it's helpful to monitor the peak flow at the same time. If the cough gets better, it may or may not be due to inhaled steroids, but certainly it can be due to cough variant asthma with no variation in the peak flow. But if you see the peak flows vary in a manner characteristic of asthma, the diagnosis is absolutely clear and it's very straightforward. And it's important to ask about sinus problems and nasal problems, and to treat rhinitis and sinus disease and postnasal drip. And those are the 3 common causes that are described for a dry cough. As background tests that you might like to consider, it's good to carry out a blood count. You can look for an eosinophilia, which should be suggestive of asthma, and you may want to measure an IgE and RAST tests to aeroantigens, which again would point to a more allergic sort of condition, be that asthma or part of the cause of rhinitis. Obviously those will not be completely diagnostic on their own, but they may be helpful in giving clues as to what the correct diagnosis might be. Spirometry is always important in respiratory disease. In dry cough, the spirometry is really going to be looking at helping you to look for asthma along with peak flow measurements, and you may need to do this more than once to look for variability if there's no initial sign of airflow obstruction. And in wet cough, it's going to help you to distinguish between simple chronic bronchitis, where there shouldn't be airflow obstruction, and COPD, where there is. And obviously there'll be somewhat different treatments as a consequence. And as well as doing spirometry, it's good practice in all respiratory disease to check oxygen saturations. For most of the simple causes for cough, you would expect these to be entirely normal, and if they're abnormal, that would alert you to more significant underlying respiratory disease, where there might be a more unusual diagnosis. It's quite difficult to know exactly who should be referred for further investigation. If you've carried out the screening tests that I've described in patients with dry cough, and they've had the trials of therapy, there are a large number of additional tests that can be carried out, but the pickup rate is going to be low. And quite often you find you get through a lot of extra tests and you're really, to be honest, none the wiser. And some of those tests get more invasive and a bit more unpleasant. They can be carried out, and occasionally they'll throw out extra options, but often they don't. And I think it's appropriate to have a conversation with your patient and decide just how much the cough troubles them. If they find it very, very troublesome and they really want something to be done, then we can look into it further. However, if they feel the cough's not deteriorating, if it's been stable over a period of time, and they're reassured by the negative tests that you've done, I wouldn't regard referral on as mandatory. It would probably be good practice after 6 months to repeat spirometry and the chest x-ray to ensure that there is indeed stability there. But I think it really is, as it indicated, a conversation with the patient about just how much trouble they're having and whether they feel it is worth their while going through a complicated series of investigation with a law of diminishing returns. There are some extra treatments that might be advised from secondary care for what's called cough variant or cough hypersensitivity syndrome, which uses some rather more unusual medications, and you probably would want to just explore the cough a little further before recommending those. But the drugs, to be honest, are not of great efficacy even then. So it is a difficult balance and something that you need to judge in conversation with your patients. In your patients who've got a wet cough, a productive cough, then the question here is really around whether they've got bronchiectasis quite often, or whether they've got bronchitis. A part of COPD is quite a common thing, as opposed to some simple chronic bronchitis related to smoking. And here patients are often going to require a CT scan. And if they have got bronchiectasis, there are a number of further investigations that would be appropriate. And if it would be reasonable for the GP, if you are highly suspicious of bronchiectasis, with large volumes of sputum, with repeated infection, it would be reasonable to request a CT scan at that stage. But I think if it demonstrated bronchiectasis was present, it would be good practice to refer to secondary care for some further screening tests. It might only be one visit and then a return with a management plan, but I think it would be good practice to check for underlying causes of bronchiectasis, which are many and varied. So first of all, there are the patients with the worrying red flag symptoms who you're going to refer immediately under the 2-week wait system. Then there are the patients who've got a possible occupational cause and are quite difficult, and it's likely you want to refer those patients to the occupational lung department within the Northern. And whilst they're being prepared for that, it's worth getting a chest x-ray, blood tests, and getting them to monitor the peak flow on work days and on ordinary days. There's then the patients with the productive cough, where you're going to check for pathogens, treat, and if you think the patient might have bronchiectasis with lots of phlegm and repeat infections, request a CT scan and refer if there's evidence of bronchiectasis, and you can refer into the bronchiectasis service at the Northern in the normal way. For the patients with dry cough, you're going to exclude iatrogenic causes, particularly ACE inhibitors, and then you can try a trial of therapy with inhaled steroids, with vigorous anti-reflux therapy, and treatment of any nasal problems, having excluded further causes by spirometry, chest x-ray, and the basic blood tests I've mentioned. If the patient has prominent nasal symptoms, you may wish to refer to the ENT department to see if there's any medical or indeed surgical treatments that can help. If the patient's had the trial of therapies that I've indicated and still has a persistent cough, then it's important to have a conversation with the patient, and if they feel their cough is still troublesome, then you can consider referral on. And there are options there. One option would be to refer using a form on the press portal to the Community Respiratory Diagnostic Clinic. That's quite a suitable place, but there is quite a long waiting list due to capacity issues there. The alternative would be simply to refer to one of the general respiratory clinics within the Northern General in a normal way. If there is capacity in the community clinics, patients can be triaged back out by agreement if suitable.